The standard practice is to treat people who are at a high risk of thrombosis with hydroxyurea. That's a chemotherapy that you give by mouth, but it doesn't work in everybody. In about 20% of the patients, you have intolerance or resistance to it that develops over time, and then you need something else. And recently, relatively speaking, a new medication called ruxolitinib was approved for these patients in a second-line setting after hydroxyurea as a therapy. Ruxolitinib is a JAK inhibitor. It inhibits the JAK-STAT pathway, which is underlying biological problem in Polycythemia Vera and other myeloproliferative neoplasms that make cells grow. So the activity of ruxolitinib in second-line setting has been very well described in the clinical studies, where it controls, when compared to best available therapy, these were randomized studies, it controls very well the red blood cells, white cells, platelets, it decreases the spleen and improves the quality of life. There were two studies actually. One in patients that had a big spleen and on patients that did not have a big spleen. So the presence or absence of the spleen as a decision maker for utility or use of ruxolitinib in second-line setting does not matter. It is very effective in controlling blood cell count and symptoms in majority of the patients. What we realized since then that the study definitions of response are very rigorous, and that many more patients that by the study design were non-responders actually have a clinical benefit. We utilize this term clinical benefit to say that there is significant improvement in the blood cell count and a decrease in the rate of a phlebotomy, which is a bloodletting that you do in addition to pills. And there is improvement in the quality of life despite these people being labeled as non-responders.